Greetings and welcome. My name is Annette Vegas. This session is on ultrasound pitfalls. We are going to begin the talk by reviewing a few questions and over the talk answering these questions. Question 1. What structure is shown in this clip? Question 2. What structure is shown in this clip? Question 3. What structure is shown by the arrow in this clip? Question 4. What structure is shown in this clip? Question 5. What finding is shown in this clip? Pitfalls are errors in interpretation of normal structures mimicking pathological entities, which may result in unnecessary clinical interventions. Pitfalls generally fall into three categories: structures, echo-free spaces, and foreign material. TEE shows many remnant structures from embryological development. Pitfalls should not be confused with this ancient video game called Pitfall, which I grew up with. Question 6. This is all about understanding and identifying anatomy and remnants of different heart structures in the right atrium, right ventricle, left atrium, left ventricle, aortic valve, pericardium, aorta, and interatrial septum. We will be using clips from this website to illustrate these structures. What finding is shown? Identify structures within the right atrium and correlate this with 3D TEE. Specifically identify and have a good understanding of the location of the structures listed here: the pectinate muscles, crista terminalis, coronary sinus valve, and IVC valve, shown in this clip. The eustachian valve is a remnant of the embryonic valve of the IVC, which directs oxygen-rich vena cava flow towards the interatrial septum and left atrium in the fetal heart. It is a crescentic-shaped fold of variable size in the posterior margin of the IVC. It occurs in 25% of patients. It is named after Bartholomew Eustachius, an Italian anatomist who also described the eustachian valve in the ear. In echocardiography, it is a linear, independently mobile structure at the RA-IVC junction seen in the bicaval and mid-esophageal views. Rarely, it causes clinical findings, but may obstruct IVC flow, mimic tumor, thrombus, vegetation, and complicate IVC cannulation. The Chiari network is the embryological remnant of the right-sided venous valves of the IVC and coronary sinus. It occurs in 2 to 13% of normal hearts at autopsy and is named after Hans Chiari, an Austrian pathologist, who is also associated with the Arnold-Chiari malformation and Budd-Chiari syndrome. The Chiari network is a thin, web-like fenestrated membrane that attaches along the ridge connecting the vena cava and interatrial septum. It is thought to be a variant of the eustachian valve. It appears as mobile, curvilinear structure in the right atrium, seen in the bicaval view. It arises from the orifice of the IVC and is more mobile and thinner than the eustachian valve. It may mimic tricuspid valve vegetation, flail tricuspid valve, thrombus, or pedunculated tumors. It is clinically insignificant, but may cause problems during percutaneous procedures with entrapment of right heart catheters. Cor triatriatum dexter is a prominent eustachian membrane that divides the right atrium into two chambers, a posterior medial venous chamber with the connections of the caval veins and coronary sinus, and an anterolateral chamber with the right atrial appendage and vestibule of the tricuspid valve. The membrane originates from the IVC and connects distally to the interatrial septum, separating the right atrium into a true double chamber. The location of the coronary sinus can be variable, but is often located proximal to this membrane. This membrane has variable size, redundancy, and number of fenestrations, resulting in a variable degree of inflow obstruction to the right atrium and tricuspid valve. This condition is hemodynamically insignificant in adults because there is incomplete septation of the eustachian valve. The presence of a PFO or ASD is also variable and may be located either proximal or distal to the membrane. When present, this ASD can act as a pop-off valve, allowing right to left shunting in patients with significant obstruction. The crista terminalis is a well-defined fibromuscular ridge separating the smooth sinus venereum and trabeculated right atrium. Externally, it corresponds to the sulcus terminalis, and internally it extends from the SVC to IVC along the lateral right atrial wall. It appears as an echogenic mass representing the muscle ridge at the anterior SVC-RA border, seen in the bicaval view. It moves with the heart and may thicken and enlarge during atrial systole. It may mimic a right atrial tumor or vegetation. The Thebesian valve is an endocardial right atrial fold at the orifice of the coronary sinus, seen in 60 to 90% of the population. It is named after Adam Christian Thebesius, a German anatomist. It appears in the posterior right atrium between the tricuspid valve and IVC in the coronary sinus view as a thin echogenic linear structure that moves with the heart. It rarely obstructs blood flow from the coronary sinus, but may complicate coronary sinus cannulation or mimic thrombus and tumor. Pectinate muscles are parallel ridges in the walls of the atria. They are named for their resemblance to the teeth of a comb, as in pecten. They appear behind the crista terminalis of the right atrium. The pectinate muscle folds act as a right atrial volume reservoir during adverse loading conditions. They are seen as echogenic masses in the atria and more prominently in the appendages that move with the heart in the mid-esophageal views. They may mimic thrombus or vegetation. The moderator band is a prominent trabeculation of the right ventricle, extending from the base of the anterior papillary muscle to the interventricular septum, which contains the right bundle branch. It is present in most normal adults, but with tremendous individual variations in thickness and shape. It appears epicardial fat is located between the outer wall of the myocardium and the visceral layer of pericardium in the atrioventricular or interventricular groove. Pericardial fat is located between the visceral and parietal pericardium and anterior to the epicardial fat. Excessive fatty infiltration tends to occur in female, old, obese, diabetic patients. Epicardial fat appears as echo-free space, mimicking a pericardial effusion in echocardiography, and is differentiated based on echogenicity, texture, mobility, and location. The Coumadin ridge is a normal anatomic variant found in the left atrium. It is left atrial tissue between the left upper pulmonary vein and left atrial appendage seen in the midesophageal views. It can present as a linear or globular fatty Q-tip-like mass which moves with cardiac motion. If particularly prominent, it can mimic a tumor or thrombus. Fat is more. The left atrial appendage are variable in number: 1, 20%, 2, 54%, 3, 23%, and 4, 3%, and have variable shapes such as cactus, windsock, and chicken wing. The left atrial appendage contains the pectinate muscles. In the midesophageal views, these appear as triangular in shape with a narrow orifice which contains echogenic parallel tissue ridges. The pectinate muscles may mimic thrombus and require careful examination in the presence of atrial dysrhythmias and smoke in the left atrial appendage. Inversion of the left atrial appendage during cardiac surgery may mimic thrombus. Echogenic and lobulated. Left ventricular bands or false tendons are fibromuscular structures that cross the left ventricular cavity. Left ventricular bands may pass between papillary muscles or free walls, from papillary muscles to the interventricular septum, or from the free wall to the interventricular septum. True chordae tendini connect the papillary muscles and mitral valve leaflets. False tendons occur in 55% of normal hearts by autopsy study. Left ventricular bands appear as string-like thin bands in the left ventricular cavity in the midesophageal views, which may be transverse, longitudinal, or sagittal, and single or multiple. The location, direction, length, and thickness of LV bands vary depending on their embryonic origin. Muscular bands become shorter and thicker in systole, and vice versa in diastole. Their presence or absence does not affect left ventricular function, though they may be associated with thrombus or arrhythmias. And fluid. with homogeneous. The nodules of Arantius. Each aortic valve cusp shows a central area of fibrous thickening corresponding to the nodule of Arantius. These are named after Julius Caesar Arantius, an Italian anatomist. These are seen as thickened nodules at the point of coaptation in all aortic valve cusps in the mid-esophageal aortic valve short axis and long axis views. The nodules are associated with Landols excrescences and may be calcified and mimic vegetations. Echogenicity. Landols excrescences are fine strands on valves composed of acellular connective tissue cores and elastic fibers. The filamentous lesions are degenerative changes that occur in 90% of the population on the mitral valve and aortic valve arising from the nodules of Arantius. They appear as thin mobile threads, less than 1 millimeter thick and less than 1 centimeter long, arising from the free borders of the ventricular surfaces of the aortic leaflets. Adjacent excrescences may stick together to become a giant Landols excrescence. They move with valve motion and cause no functional abnormality. Rarely, they may be a nidus for bacterial growth or cause systemic embolism. They can mimic vegetation or tumor. A fibroelastoma has a thicker stalk and is pedunculated. An lipomatous hypertrophy of the intraatrial septum. There is excessive fatty infiltration of the intraatrial septum, resulting in prominent thickening. The fat is contiguous with epicardial fat pads. It is not a true tumor like a lipoma, which is encapsulated. There is marked atrial septal thickening of greater than 15 to 20 millimeters, often with sparing of the fossa ovalis, creating a dumbbell shape of the intraatrial septum, seen best in the midesophageal bicable view. The superior mass is the fat-filled groove between the atria. The inferior mass is between the ventricles. This can mimic other causes of septal thickening, such as amyloidosis, tumors, and a surgical patch covering a repaired atrial septal defect. This is generally a benign condition and asymptomatic. However, blood flow obstruction of the SVC and coronary sinus, intra-atrial conduction disturbances, supraventricular arrhythmias, syncope, and even sudden death have been reported. Anteriorly located intra-atrial septal aneurysm is an excursion of greater than 10 millimeters beyond the plane of the intraatrial septum that may involve the fossa ovalis or the entire intraatrial septum. It is found in 1% of adults at autopsy. The redundant intraatrial septum shows passive oscillation with the cardiac cycle greater than 1 centimeter beyond the atrial septal plane in the midesophageal bicable or four-chamber views. There is frequent association with ASD, PFO, mitral valve prolapse, and Marfan syndrome. It may develop from long-standing elevation of atrial pressures with bulging towards the lower pressure atrium. It is associated with atrial arrhythmia, ischemic stroke, and PFO. It can mimic a cystic mass. Immobile echo-free space. Normally, the innominate vein or left brachiocephalic vein lies anterior to the transverse aorta. However, it may traverse a retroaortic path. This can be differentiated by color and spectral Doppler, with low flow shown in the innominate vein. An injection of agitated saline into a left arm vein will show contrast enhancement of the left brachiocephalic vein, as shown here. Clinically, it is associated with congenital heart disease, tetralogy of Fallot, and right-sided arch. It may mimic a localized dissection of the transverse aorta. Is likely to be. The other causes of potential pitfalls are echo spaces, such as a persistent left-sided SVC, transverse sinus, oblique sinus, and both pericardial and pleural effusions, epicardial fat deposition. The transverse pericardial sinus is a space that lies posterior to the ascending aorta wall and anterior to the left atrium. It is best seen in the mid-esophageal aortic valve long axis and mid-esophageal right ventricular outflow tract views as an echolucent space that contains a small amount of fluid. It does not have color Doppler flow, but may contain fibrous material or the left atrial appendage tip. It can mimic a cyst or abscess. Persistent left SVC. The oblique pericardial sinus is a space that lies posterior to the left atrium. It is best seen in the mid-esophageal aortic valve, long axis, and transgastric views. It is an echolucent space that contains a small amount of fluid. It also will have no color flow. This arises. Pleural fluid in both thoracic cavities can be imaged with TEE. TEE can also be used to detect lung atelectasis. There is an absence of color flow in an echolucent space. Pericardial fluid surrounds the heart and may compress chambers. It may also contain fibrinous material, and again, no color flow should be demonstrated in an echolucent space. From failure of the left. Foreign materials such as catheters, pacer wires, and sutures may create pitfalls associated with normal imaging of these materials. Posterior cardinal vein to resource. Shown here are two examples of pacer wires. A pacer wire has passed through a PFO in the interatrial septum and now lies in the left heart. A large thrombus is seen in this pacer wire. Which connects to. Here are some useful readings associated with this topic. The coronary sinus. It is more common in patients with congenital heart disease. Echocardiographic findings consistent with the diagnosis include an echo-free space between the left atrial appendage and left upper pulmonary vein, with color flow within the space, as shown here. An enlarged coronary sinus of greater than 2 centimeters in diameter, and left-sided arm vein injection that goes into the coronary sinus. The pathology is associated with coarctation, ASD, VSD, and chorotriatriatum. It can mimic a cyst or abscess rather than a pericardial effusion. CT imaging can definitively differentiate epicardial adipose tissue from fluid collection in complicated cases. As a thick, echo-dense, band-like structure across the right ventricular cavity connecting the lower intraventricular septum and the anterior papillary muscle in the mid-esophageal four-chamber view. Importantly, it can distinguish the right ventricle and left ventricle and may mimic tumor, thrombus, or vegetation.